I'm going to channel my program director voice instead of my chief of spine voice, so people can wake up and it's getting there. I think sodas and coffees are in order, so I'll keep this really short. All right. So one of the things that I do a lot of is cervical deformities, and I do encounter a lot of variations in skin in this baby, if I should say, because the other word is foul. Anyway, what I want to talk today was avoiding iatrogenic cervical deformities, i.e., let's not create a cervical deformity while we're at it. And really, it's more of avoiding pitfalls that I've talked about before. It's on SSTV, and really getting a framework and understanding of what to do when you see it, right? So I have disclosures that are related to education, and nothing concerning this talk. So I've had some prior talks here on SSTV in 2023, 2024, and I also have a case examples and techniques. So really, when we talk about cervical deformity, we're talking about any abnormality in the alignment, shape, or formation of the cervical vertebral column. And the etiologies, all of you get it through your education: degenerative disease, neuromuscular disorders, congenital, and with a focus on iatrogenic. We're talking like post-laminectomy syndrome, post-fusion syndrome, things that we do that will get us in a situation where the patient now has more of a deficit related to a intervention, either a misplanning or bone substrate quality, etc. So a little bit of biomechanics, which I talked about in my other talk, will be we're well aware of the 6 degrees of freedom in the cervical spine, flexion, extension to posterior translation. And it's in the cervical spine, we talk about the biomechanical axial loading sustainability of it. And we also appreciate that in the subaxial spine, we do have posterior elements that carry about 2/3 versus the intervertebral disc and body, which is 1/3. Conversely, we're not having a thoracolumbar fracture talk this year, but it's sort of reversed in the thoracolumbar spine. It's almost 80-20. So different forces acting differently in this region from an axial load present with more repercussions, right? So example, if we create a kyphotic event in the cervical spine, it begets more kyphosis. There's loss of lordosis and a shift of the center of mass, which increases the bending moment and increases the axial load anteriorly, which is prone for worsening kyphosis because it carries 1/3 versus 2/3 of the loading capacity. It therefore increases muscle fatigue of the patient. So people present with neck pain, neurological deficit, cord stretch, think about that, myeloradicalopathy syndromes, and oh no, Dr. Jens Schapner is not here. I was really ready to say this. All right, and this, Charlie, what's it called? Dysphagia. There you go. And also respiratory syndromes and also lower back pain. Why lower back pain? This was a concept that up until 15 years ago was really hard for anybody outside of the neuromuscular pain, PM&R, to sort of figure out. Surgeons were sort of, how is your neck pain causing your lower back pain, until the advent of long cassette scoliosis imaging applicable to adults versus only pediatrics was when that became, all right, my back hurts because my neck is out of alignment, etc. So what's the implications of cervical deformity on spine balance, right? We know that the cervical spine, I talked about head over body, maintaining of a level horizontal gaze, and also center of mass. So why is it the cervical spine lordotic? Really, it's to compensate for thoracic kyphosis, which is needed for lung volume. So it's a repercussion of a repercussion, right? Thoracic kyphosis is needed for lung volume, to maintain level horizontal gaze. The neck has to be thrown backwards in the lordotic. angle. So as you age, as you lose that, as you let a patient lose their neck ability to compensate, it increases their pain. So you have an example of a normal alignment, head over pelvis, center of gravity, less economy of movement, and also less energy expenditure, right? Versus a hyperkyphotic versus a hyperlordotic. All the compensatory arms are in play. Now, what does it mean to have a cervical deformity? In terms of any adult cervical deformity, you look at the EQ5D, the burden of that is literally in between somebody with really chronic emphysema and more morbid conditions, near blindness, etc. So if you look at the burden of disease of cervical deformity is very high, and so any attempts at rectifying this tends to improve their quality of life. And things that we look at in this day and age, currently every year, more people know about cervical measurements, as C2, C7, SVA, the amount of change or shift from the center of their whole cervical spine. Even in a patient who's lordotic, if their alignment or SVA is shifted, either retro or anterior, it does cause a change in how to look at the world perspective, and also neck pain, cervical thoracic pain. Tomorrow, Dr. Jens Chapman is going to go to more detail about SVA and its implications, et cetera, in the cervical spine. One of the things that we always also are very concerned about these days will be chin-brow vertical angle, how people perceive things. And this is all also translates to the cervical thoracic junction in terms of pain and disability, right? How they stand, how they flex their extremities to maintain a lordosis, and also horizontal gaze, right? We're all doing this for horizontal gaze. So in this day and age, we're well aware, all of you are well aware, you've read about it, you know about it, that the cervical spine cannot be evaluated as a standalone region, right? So there are focal and dynamic measures of importance, and thoracolumbar malalignment impacts cervical spine. One of the measurements that has had profound effect in how we treat cervical spine disease and also cervical thoracic disease has to be the T1 slope, which is a more applicable parameter in order to figure out how much lordosis do you need to maintain your cervical SVA and total SVA. So if you have a small T1 slope, you need a smaller cervical lordosis to maintain horizontal gaze versus a large T1 slope, large lordosis to maintain it. And really, this could be iatrogenically done, or this could be a result of normal degenerative physiology. So in the first panel to the left, the patient who has had their thoracic capacity being restricted, has adjacent cervical disease, they now have a large T1 slope and require a larger C2, C7 lordotic angle to maintain their horizontal gaze. This is all about quality of life, maintenance of horizontal gaze, versus the patient in the middle panel who sort of have a balanced look of life versus the other patient. So if you look at all these three patients, their pain scale varies, and as pain is very subjective, you realize that the patient to the left has more pain than the patient in the middle versus the patient who does not have a lot of thoracic kyphosis. Hence, they have a reduced T1 slope and need less angulation, right? So what do we do? What do we do to patients that will put us in a predicament where down of that chart that I showed you, we will have more iatrogenic side effects, which include post-laminectomy kyphosis, right? So 21% of post-laminectomy complications include having myelopathy after surgery. This is seen in children, but also in adults, right? For any decompressive procedures that we do, it's increased with facet disruption. And it could lead to the worst, or as they call it, Dr. Hamilton's clinic on Friday, which is a dropped head syndrome with chin on chest deformity that is flexible. That's my pre-op outlook for most patients. However, one of the things that I do want you to have in your mind when you see this, particularly if they have intact posterior elements, have never had any surgery, or even have had surgery, because they could have a misdiagnosis and then having laminectomies to help with their neck pain or stenosis, will be, do they have neuromuscular disorders? Always have in the back of your mind, anybody whose physical exam outweighs anything that you're doing, neuromuscular disorders, vitamin deficiency, and even isolated neck extensor myopathy, right? So you have to have that in your back of your head. At every clinic where things don't add up, is let's go outside what we're looking at. And it's so easy to fall into imaging, pain, surgery. So I'm going to be brief in the interest of time. I took out a lot of slides from this because a lot has been mentioned in my prior talk. Will be, at this point, we do have a lot of classification systems to figure out what do we do and when do we do it for anybody who presents with cervical deformity. I like to go with the simplest of them all, which is the AIMS ISSG classification system, right? So you have cervical deformity classification. You look for the deformity descriptor, the primary deformity descriptor, which will be C for cervical. Do they have a primary sagittal deformity with the apex in the cervical spine versus cervical thoracic, or like I said, a thoracic primary sagittal deformity. And sometimes they may have a coronal deformity. Those are the hardest to evaluate, fix, and make sure that you're not putting them in a worse predicament. And sometimes you may even have a craniovertebral junction deformity where you can have basilar invagination, assimilation, etc. And then you look at modifiers, right? Look at where the SVA is, less than 4 centimeters, versus where the horizontal gaze lie. And cervical lordosis minus, the T1 slope, you want it to get to a less than 15 degrees. And also, then you add the physical exam, myelopathy, and then you also add the thoracolumbar Schwab classification. So if you have this in your mind, you have to say to yourself, if somebody walks in my clinic that quote unquote has a myelopathy, and I'm thinking about doing, a C3 to 5A CDF, perhaps I should get standing x-rays. Perhaps I should, interest them in getting EOS. I need to look at how everything looks before I say, well, I'm just going to do 3-level ACDF, 2-level ACDF, a single-level ACDF, and that'll be it. One, it helps you understand what's going to come down the line. Two, it also gives you an appreciation of how the deformity is contributing versus a disc herniation, which is giving you a pseudo deformity, versus also your own interpretation of down the line. There are practical classification applications from the AIMS classification, but here's some of the things that I wanted to jump to. Things to do and know in this day and age. I mentioned about it. When somebody has a cervical malalignment, think about the cord being stretched and sequelae associated with that. However, the surgeries that we do are not without consequences. We always have to think about the neurological injury you're going to be possibly encountering. I have seen, people show up. We preemptively give them a tracheostomy based on the amount of surgery we're going to do, even a peg tube, if we know that they have a shrunken or shriveled esophagus and we are making huge decisions as to their realignment, right? And of course, infection, and you may fail with your alignment goals. So one of the things that I always talk about as part of the avoidance is, what is their physiological age? How many here know how to have an algorithm of calculating somebody's physiological age, including frailty, bone quality? These are things that I could spend, an hour or two talking about, but we want to talk about bone density. And I try to use all the modalities I have, from a, opportunistic CT scan, including a DEXA scan, and see if there's a difference between the two, versus anytime I look at anybody's flexion dynamic imaging and I realize that we have a rigid deformity, I start thinking to myself, two surgeons are better. I need to have, this goes beyond my fellow and myself. I need to start thinking about a co-surgeon. And I implore all of you to have that thinking, no matter how well. If you're a fellow or resident and you're going out, you have to think about, where am I going to be? Who's going to be my partner for these big cases that I enjoy doing, right? How obese is the patient? What's the general health of this patient? Do I understand concepts as surgical invasiveness scale, and what kind of deformity plan do I have? And I always say, go beyond what your imaging, your navigation is going to do for you. Start thinking about putting it together with the patient substrate, and also how you can improve that. Do you have a center that's going to help you optimize these patients beyond their PCP? And is that center tied in with your anesthesiology team? And always, are you thinking about staging these cases? It's very important. And I'm sort of highlighting things that get into a situation where either you're calling your senior partner, getting an intraoperative consult, and that's, you went from imaging to patient exam to the OR, right? There's a lot that's in between that I'm always advising, consulting, and sort of educating my junior partners, residents, and fellows. But everything else, we like to measure, quantify, and decide what to do. So I also have to have this nice table. This came from Dr. Vaccaro from Jefferson, and it sort of classifies this into rigid versus flexible, and an additional measures, including those are ankylosed. And with flexible, they talk about doing anterior cervical corpectomies, posterior decompression, versus the non-ankylosed spine. It's a great way of having a general look of how things go. But then in practical applications, you have to see that at the furthest end, or at the end of care, we're talking about posterior osteotomies and also anterior release interbody instrumentation for the fused posterior versus pedicle subtraction osteotomies. So at that further to the right, involves a lot of surgical invasive procedures versus realignment for the flexible spine. So when we go through that, we have to say, let's categorize. So in the ISSG, we just came up with a few categories that made sense. Patients who had a flat neck, patients who had a focal kyphosis, these are anterior procedures, realignment procedures. Patients who also had cervical thoracic kyphosis, this will require more realignment, longer instrumentation, and patients who had a coronal deformity. Now, it gets really tricky with patients with coronal deformity because you have to look at their total realignment. And in all of these situations, they always come with advanced degenerative disease with myeloreticopathy, stenosis associated. So what would I think would be the best way to do it? And I kind of look back at this paper from the ISSG, and it's always a great assessment of surgical treatment strategies for moderate to severe cervical deformity. And there is some variation in how we do it, right? So if somebody has a moderate mid-cervical apex, right, cervical kyphosis in the middle, it was sort of split, anterior versus posterior. And I sort of look at anterior, if I'm thinking something that's flexible, does not have a rigid posterior elements, I would like to do an anterior approach, right? These are my corpectomy, ACDF/corpectomy reduced to less than 3 levels, right? And then if you think about a cervical kyphosis with the apex at the cervical thoracic junction, I need a more powerful movement arm to restore alignment. And typically it's mostly posterior. Lots of posterior column through and through osteotomies and realignment with cantilever of the rods. We will do some of this in the lab tomorrow. Now, when it gets to be chin on chest, it really begets getting a good view of whether you need anterior release. You can have somebody with chin on chest with a rigid anterior ACDF where you have to go in the front and do a release. At that point, and then you're going to do posterior cervical osteotomies. At that point, you have to really start thinking about what I talked about pre-operative swallowing and also feeding plan, as well as staging this. This is not one where you're on call during the week, or God forbid, you're in a place where they've encouraged you to, right off the bat from training, have two rooms. That I would be very leery of a place that allows you to do that right off the bat, right? So, overlapping surgery, it's not the day for a chin on chest deformity surgery. Now, if you have a mild cervical kyphosis, most people, it's sort of dealer's choice. You can restore really well with a anterior surgery, right? So cervical thoracic. So when I look at some of the techniques that I do, I quickly go to posterior column releases, where through and through in between the interlaminar space and getting through the facets, it's very easy to slide a small Woodson and drill over, protecting the neurovascular elements in the lateral edges of the posterior spine, versus doing a laminectomy to actually see a release. Anytime I'm thinking about cantilevering the posterior elements, I want to see everything really clearly. There's nothing like finishing a big surgery and then realizing that you've given them a radiculopathy. It's back to a release, and you wouldn't be able to tell from getting an O-arm spin, etc., right? Sometimes you have to end up doing an open wedge osteotomy. We're not going to be doing that this lab. That's a sort of a tricky procedure to do, but definitely closed wedge osteotomy that's at a far level is much easier to do. I would like everybody to take a look at this. Is a landmark paper. You should go read it about how to get a posterior column osteotomy and also it's a great technique if you're very concerned about your blood loss and also maintenance of this surgery. I should call it, not getting this surgery out of your hands, but how do I do a very systematic procedure for posterior pedicle subtraction osteotomies and implications. I read this right when after my early days and as an attending, and I still really like it. But really, when we think about posterior, cervical thoracic pedicle subtraction osteotomy, the only thing that I always worry about beyond, cord damage is what I talked about, which is, avoid nerve compression. We're now going to be cantilevering the posterior elements. We really want to be able to see the nerve roots in totality. Don't be afraid to say, I don't want to, I felt it, and so it's loose. That's the kiss of death. If we're going to be compressing posteriorly, we really need to see all the nerve there. And of course, anytime I'm doing this post-laminectomy, there's cord buckling. It's far easier to get the right and the right medicine bomb to take off the scar tissue, and if anything, sew a pinhole durotomy. In the posterior elements, anytime you're doing deformity surgery, you get a large durotomy. Sew it now. Don't pack it. Sew it, because if you lose your buoyancy, you're not going to be able to tell very much how much of the decompression have you done before you clamp down or on your osteotomy site. So I always encourage people, yes, we're trying to avoid leaving a dense scar tissue on the dorsal spinal cord, but we really also want to make sure that we take care of any CSF egress. So what are some of the pitfalls? Now let's talk about, you're out there, you had this case, you've assessed that your hospital will be able to handle this. You have been well trained, you can handle this, right? And you do have partners, and you do have intraoperative help, right? So negative persistence, right? You're in the case, it's not going well. You sewn the durotomy, signals have gone in and out, and you're in the middle of it. Just avoid negative persistence. That's the kiss of death in all of this, right? If you plan on staging these cases, restaging intraoperatively is not a defeat. I'm going to say it again. if you plan on staging a big cervical deformity, any surgery, and they don't align with your goals, things in surgery, blood loss, etc., restaging, the minor inconvenience of closing, coming back versus, persisting because you've got a big clinic and the hospital is giving you some metric about how much clinic cancellation and you have 4 ACDFs the next 2 days. Doesn't matter. What matters is what you're doing right there. And you have to remember what I'm saying right now, because a lot of things that I adjudicate externally involves negative persistence. That's the kiss of it. It's not we slipped and there's a major injury. It's called we kept going when we knew or didn't have the review of stopping, right? You have a big CSF leak. You've spent 4 hours fixing that CSF leak. You look at the time, it's now 3 p.m. You're supposed to go somewhere, do something. No, that's not a time to grind through the rest, right? Excruciating blood loss, right? You're now 2 liters in and you're barely started your deformed surgery, right? This person's INR, PT was perfect. Perhaps they weren't checking for you, right? If you have a major vessel injury, tracheoesophageal injury, those are pause events, right? And of course, you have no co-pilot. You're by yourself with an APP that was assigned. You're 7 months in, everything's going smoothly. You've seen your performance review of your first 6 months, and the vice president of clinical affairs in your hospital is giving you nice email updates. Yeah, well, today's not one of those. Let's pause. And really, if your OR staff is not up to snuff, you've had a lot of people who are not, routine staff members, and you haven't invested time in their training, etc. You may have to, as Dr. Abdul Jabbar said, go into the OR early. Plan on going to know who's in the OR that day for this procedure. Nobody's doing a cervical deformity emergently. So it's been on the schedule, it's been on the books for 3 weeks. You need to start talking, alerting people that this is what's going to happen. And you'll be surprised how things come together if you do that, right? Do it before you have to present it on M&M if you have that. So there's a lot of complications associated with cervical deformity surgery, up to 2 to 3% mortality. Major medical and also neurological complications abound, but the complications include dysphagia. Is that the right word to say? Yeah, okay, and hoarseness, neurological deficits, hardware failure, but people do well if it's done properly. The improvement in their life is beyond. Sometimes the most rewarding 6 weeks of clinic visit that I have, right? Their outlook in life, how they are being perceived, etc., is very impressive. And multiple papers are now showing us that if we are able to get to the right alignment goals and decompression, it's successful, right? And I mentioned, don't do this when you're on call, right? Overlapping surgeries, not a good idea. And you really have to be a synchronized team when you're doing this. And prepping the patient is super important. The substrate, bone quality, habits, smoking, these are all modifiable issues. And so I've had somebody wait 6 months with a chin and chest deformity just because I needed to get them appropriate early disease-modifying medications before we started any deformity surgery. It's not a bad idea for people to have neuropsychiatric testing even before you start. Get them a second opinion. Meet your co-pilot. Have a pre-op clinic. That's not yourself and the PCP alone, right? But, there's an opportunity for us to do some close wedge pedicle, opening. Let's not focus only on placing implants, but also doing the drilling and the bone work. How do we safely get through, by good graces of the cadavers? They're not going to complain a whole lot if we're going to drill right through and say, I've been doing a lot of decompressions, but we've never gone beyond the middle facet. This is a good time to say, let's see if I drill and go right through? Where do I feel like I encounter the end of, the overlap of the vert and also the, exiting nerve root? And basically, I always say, let's avoid negative persistence. So many iatrogenic cervical deformities are preventable, right? So you have to do a thorough assessment, anatomical, biomechanical, physiological factors, and have an individualized approach to optimizing patients. And there's a high complication rate in a debilitated patient. You have to emphasize good sagittal alignment. Tomorrow, Dr. Chapman is going to give a most wonderful talk on the cervical thoracic junction and realignment. We're going to talk a little bit more of the cervical alignment as it comes. And just so you know, the word is, Charlie? Dysphagia. Good. All right.
Right on cue.
Thank you. Right on cue. All right. Thank you. It's break, stretch. Let's get some coffee. We'll end really well. And thank you all for listening. Any questions at all? Yes.
Drop dead syndrome. My practice is cursed with those. I don't know what's going on.
Your pre-op practice.
It's unbelievable. So should we
Just to be clear.
when should we give them J tubes, G tubes, or something like that? Because most of them can't swallow for a while. Maybe the surgeon, but when we stretch the esophagus, it does not want to work very well. Most of them are quite emaciated. So, what's your practice? What's your recommendation to optimize their nutrition? And do you routinely in these more emaciated patients before you operate put J or G tubes in?
I give them the choice to say we're going to start with a DO2 post-op first, because they try as you might, if they can't swallow, they're not going to get their
My noodles now.
good. They're not going to get their pre-albumin where you want it to, etc. Right? So if they're really emaciated and they have swallowing difficulties, I just say, look, we need to get. When I look at your esophagus and how constricted it is, and we'll probably have to start with a peg tube and get your feeding up. If they're sort of saying that, well, it's hard, but they're not so emaciated, I tell them we may have to do this post-op because I'm really going to be stretching.
Because that's what I don't like. I don't like post-op. I don't like those. I don't like to wait for 7 to 9 days and coughing and whatever. I want to have some decision made beforehand and ideally 1 month of beefing up.
That's good.
Do you defer to SLP in decision makings then, or do you get your own video fluoroscopy? Which, by the way, I love video fluoroscopy. It's very entertaining to watch.
I do both. I mean, yeah, it's just like
I can only recommend that. But it's a bane of our existence. We're seeing more and more of those patients. They're very, very difficult to manage. There's so many things going on. It's really dramatic, and the core variables are significant. So thanks for mentioning that.
Like I said, there's no emergent cervical deformity surgery, so the planning is crucial, and the planning for your own self is crucial. All right, there are snacks outside. There's still some lunch if you feel like it. And we should circle back. Charlie, how much time do we have?